My name is Graham McCourt. I'm the Global KOL Manager for Biomedical. As you know, we're running a series of webinars with experts on ventilation. And today we're very fortunate to have a friend, Rich Branson. He's a professor in the College of Medicine at the University of Cincinnati and in the trauma division and critical care as well. He's also an adjunct faculty member of the USA Air Force School of Aerospace in Dayton, Ohio. Plus, his claim to fame as well is he's the editor-in-chief of the Journal of Respiratory Care. And as you know, that's one of our major journals. He's a respiratory therapist for over 40 years. He's a very strong researcher. His interests include humidification, transport of the critically ill, disaster medicine, and of course, on today's lecture, he's going to talk about automation of mechanical ventilation. He's a big fan of that. He's published over 300 papers in PubMed, edited 2 textbooks, written over 100 book chapters, as well as a fellow of the AARC and the American College of Critical Care Medicine. So what we have before us today is an expert. Now, before we go any further, if you have any communication, what we'll do, we'll use the Q&A feature at the bottom of the screen. Please use that. And at the very end, he'll speak about, say, 45, 50 minutes. We'll have 10 minutes or so for Q&A. So please enjoy what's going on. Rich, it's up to you. It's showtime.
Thanks, Graham. I'll try to live up to the introduction. So, and I have spent a lot of time in my career thinking about and actually even doing closed loop control, ventilation and oxygenation. And I'm gonna mostly talk to you about what I think the promise of it is, as well as what some of the data is to date, and hopefully, provide you some evidence where we have it and suggest evidence where we need it, and go through some of these issues that I think are important. So I think it's good to start by looking directly at what it is we do every day, this issue of mechanical ventilation that I was actually having a discussion with Rob Chaperon earlier today, mostly just friend to friend, but we were kind of lamenting the fact that even though there's been huge changes in the way we care for patients, the understanding of mechanical ventilation in a lot of areas has not improved. But I like to argue that mechanical ventilation is the reason we have intensive care unit. That intensive care units were put together in the 60s. It was a place to house the patients who were all on the ventilator. And you might argue with me about that if it's cardiac or something else. But there's one thing that's for sure: no matter what ICU you're in, neonatal ICU, cardiac ICU, neuro ICU, there are ventilators there. Clearly, the last 2 decades have probably been the biggest changes, and importantly, evidence-based changes in the way we care for patients. And that includes, of course, the issues of lung protection, targeting a normal oxygen saturation, avoiding both hyperoxia and hypoxia. This concept of diaphragmatic protection, reducing ventilator-induced diaphragmatic dysfunction by encouraging triggering the patient, to be assisted by the ventilator. And of course, in the early 2000s, the change from weaning to liberation from mechanical ventilation using weaning screens and daily spontaneous breathing trials. But even with all these big improvements, we're finding more and more issues we have to deal with. What about asynchrony? It's fairly common. It goes unrecognized a lot of times. Obesity is a problem around the world, alters chest wall compliance, and might change the way we think of what's safe for mechanical ventilation. And there, of course, the use of esophageal manometry can become important. And I think this is still debated. Hyperoxemia, too much oxygen is kind of common. It goes unrecognized, and nobody's concerned about it because it's like a lot of things that we do. If we know that if we don't treat hypoxia, there'll be instant consequences. But if we leave patients hyperoxic, we don't really see anything negative happen, even though it might take days for it to happen. And I think there'll be more focus on that. I have said in a number of talks, the group from Toronto at this point is, clearly one of the leading groups in the world with related to mechanical ventilation. And this is a paper by Ewan Gallagher from Intensive Care Medicine, kind of summarizing all this. And I know this is not what the talk's about, but it's, so I'm not going to go into everything here. But so there's the issue of how do we prevent ventilator-induced lung injury, reduce the tidal volumes, maintain a lower driving pressure, prevent excessive PEEP that causes overdistension, avoid insufficient PEEP that results in de-recruitment. Diaphragmatic injury, as I said, is important. Too much PEEP creates longitudinal atrophy, and you have disuse atrophy if there's not enough effort done by the patient. I had to tell you, I'm still on the fence about PSILI with sides, which is not the best acronym in the world, over whether these insufficient or high effort drive has injurious effects, that the patient injures themselves. I mean, clearly there are conditions where it can happen, and we see some relationship between NIV failure, really large tidal volumes, and requiring intubation. So there's something there. But I think this kind of, mechanical ventilation is a therapy of competing interests. Too much pressure injures the lung and decreases cardiac output. Too little pressure results in lung injury and hypoxemia. Not enough patient breathing results in diaphragmatic atrophy. Too much patient breathing might result in lung injury and diaphragmatic fatigue. But I think these are all, again, this is just a good slide that's newer than some of the other slides that you might have seen that kind of put all these in one spot. And so Gallagher goes by and says, okay, there are some things we want to do then. We want to have the patient trigger the ventilator. In order to do that, we have to decrease sedation. We lower the respiratory rate so the patient starts breathing more often. If that's not possible, maybe in the future we'll do phrenic nerve stimulation. In terms of excessive effort, you can monitor P.1 and esophageal pressure if you have it. I think about all the times when we used to routinely do esophageal pressure, but now that it's not difficult to do, but it's also not simple to do or place it. And I think it's not always, people aren't always comfortable using that technique. Talk about adjusting PEEP and FiO2, either according to the ARGS-NET-ARMA or ARGS-NET-alveoli tables, or through some other mechanism of adjusting PEEP. Monitoring lung stress and strain is important to optimize ventilatory support. Again, tidal volume as well as driving pressure, transpulmonary pressure if you have it. Again, and making sure that the changes that we make to reduce lung injury doesn't increase asynchrony. And of course, ECMO, extracorporeal CO2 removal, and neuromuscular blockade for short periods of time may be useful there. And then you have to continue to monitor the patient's blood gases, realizing that normal blood gases aren't as important as blood gases that are compatible with recovery. And then we'll talk a little bit more about assessing readiness and weaning liberation from the ventilator. So with that as a background, where is it that we can improve with automated ventilation? So hence my talk, what's the promise of closed loop ventilation? Well, what we hear is that it'll reduce practice variation. And that makes sense, I think, because the ventilator is essentially putting in place the protocols that we know from the last two slides we should be doing. And it doesn't depend on who's attending that week. It doesn't depend on the skill of the nurse or the respiratory therapist that day. Is it a senior person or is it somebody just started in the last couple of months? And reducing practice variation, I think, is clearly something that works. I think of it as just like a protocol. If you have a protocol, the protocol does a good job of managing those patients that are kind of, in that middle 2/3 of patients who respond the way we expect them to. Now, outside of the protocol is where expertise comes in, where what do you do with the obese patient, the patient with intra-abdominal hypertension? What do you do with the patient who has head injury and other issues? But again, reducing practice variation, I think, makes perfect sense. Automation could enhance our safety by limiting tidal volume, driving pressure and plateau. Again, the machine does what we tell it to. It can respond to changes in patient condition, which can't always be done because of our staffing ratios and the severity of illness of patients. And I think, in fact, I'll demonstrate to you with some data that this is true. Whether or not automation can facilitate ventilator discontinuation remains to be decided. There's some evidence that it leans towards the side of improving things, but not always. The other thing we often don't think of is that there are times when the automation can escalate therapy when the patient's becoming ill, rather than waiting for us to hear an alarm for a low oxygen saturation or low blood pressure. And I think, there's nothing that we can talk about today that doesn't include COVID-19. And with COVID-19, we saw when places were overrun, like in New York, just the sheer volume of patients. And everybody said, oh, if you put them on the ventilator, they're going to die, or the ventilator must be causing something to go wrong. I think as you look back at that, and there are starting to be papers that are published, that it's just simply a matter of too many patients, not enough caregivers, not enough space. And if you're asking your urology resident to take care of your ventilator patients, things are probably not going to go well. So COVID-19, and I'll show you at least one suggestion about that, is a good argument for closed loop control so that patients can get the care they need and the standard of care they need, regardless of who's taking care of them and what hospital they're in. And this is from this is from a paper in Lancet Respiratory Medicine like last month. And it reminds us back to Alan Morris, who's been talking about computerizing ventilation for 30 years. And he basically came up with, and when he was doing these studies, that for every individual patient on the ventilator, the physician has to look at about 236 different variables to account for. And he goes on in this editorial to say, it's not unusual for an intensivist in London to take care of 20 or 30 ventilators. And, he makes a very important question of how do we manage the ventilator, and isn't managing the ventilator really the center point of critical care? So knowing what's going on a breath to breath basis, it's impossible for us to know that because we just can't be at the bedside all the time. And then real quickly, so this is from LungSafe, and I just want to show you, again, the evidence for low tidal volumes and low plateau pressures is over 20 years old now. So you would say, oh, that's great because we know what to do. So LungSafe was this big multi-institutional international study looking at ARDS in 50 different countries. And I just want to show you here. So in the box that I've made on the left is people with plateau pressures less than 30 and tidal volumes of less than 8 mLs per kilo, which would be, I think we could agree, is the standard of care. But if you look, above and to the right of that, there are a lot of patients in this study, including patients with severe ARDS, getting tidal volumes of 13, 14 milliliters per kilogram, getting plateau pressures above 35. So even though we know what to do, we don't always do it. And one other part of this study was people underdiagnosed ARDS. If you looked at the patients who actually met the criteria and the number of people sites said had ARDS, they undershot it by about 20%. Following up again with the same plateau pressures and driving pressures associated with outcomes in the LungSafe study, again, kind of points to this: driving pressure less than 14 results in better outcomes than driving pressure is greater than 14. And then one paper that's fairly new that everybody doesn't look at, and this is oxygen use from the same LungSafe studies. And all I want to show you here is, so top left is PaO2 on day 1, top right is FiO2, and this is the number of patients who are hypoxic, normoxic, or hyperoxic on day 1 and day 2. And then on the bottom here is the FiO2, PO2 at day 2 in these groups. And I've seen it over and over again, and I'll show you some of our data that we've just completed, that patients tend to be hyperoxic because there's no immediate danger. If I walk by and my guy's O2 sat is 99, why do I have to worry about it? And De Jong's paper, now 10 or 15 years old, demonstrated that if patients had a PaO2 greater than 120 millimeters of mercury and their FiO2 was greater than 60%, 80% of the time people turned down the FiO2 or the PEEP. If the patients had the same PaO2 at an FiO2 of 40%, less than half the time was there any reduction in FiO2. So there's something there again to be learned about how we manage oxygen. And a computer in a ventilator can manage FiO2 a lot faster and easier than we can. And again, just the data from LungSafe, that hyperoxemia was very common. And you look at the patients here with their FiO2 at day 1 who had a FiO2 between 90 and 100%. Some of them were hypoxic, but almost an equal number were hyperoxic. Now, again, this is one I wanted to at least show you the Kaplan-Meier curves on the right, that even in this study with prospectively collected data for the most part, there wasn't a difference between sustained normoxia and hyperoxemia in the patient's outcome. And a lot of retrospective studies had suggested a signal there, but it really hasn't come to fruition yet. Although again, the evidence is still out, and it may depend on the kind of injury, and that injuries that are characterized by ischemia reperfusion are probably more sensitive to hyperoxia than others. So took the first quarter of the talk basically to hopefully set the table. So what's feedback? What's automated ventilation? What's really just feedback control. And this is just a simple system that looks at, it's a negative feedback controller. I tell the machine what I want, what the input is. I have the machine try to deliver that input. In this case, we're looking at tidal volume. I measure the tidal volume. And again, it's usually tidal volume that's delivered from the ventilator, not exhaled. And I compare what I want versus what's different, and I try to make the difference 0. But all ventilators use closed loop control. Any type of pressure ventilation is using the pressure signal as a feedback to decelerate the flow. So it's not like closed loop has not been with us for the last 30 years. And pressure support would be the simplest example of that. So what can we use? MMV was invented before there was such a thing as a microprocessor. It was a completely mechanical system. Adaptive pressure control is another type of closed loop ventilation, which would include PRVC, APV, volume control, whatever your ventilator calls it. We have adaptive support ventilation, which has been around a long time now. Auto mode, been around a long time now. The adaptive ventilation mode is newer out of the IMT group, and now with the new Bella Vista ventilator. Traeger introduced SmartCare PS a number of years ago. We are looking at closed loop control of inspired oxygen, and there's IntelliVent that is ASV that includes PEEP and FiO2 control. So let's talk about a little bit about these. And this is, I'm sure you've all seen this if you've been to any talk about ASV. That is, and like AVM, is based on this Otis's work of breathing formula for a patient. And again, I'm not going to test you on the solving the equation on the bottom, but essentially Otis said, you know what, based on the resistive work and the elastic work, there is a combination of work where I can get the lowest amount of work at a respiratory rate that gives me normal gas exchange. Now, this has always been a point of mine when we talk about ASV, and that's that Otis was talking about the patient's breathing, whereas ASV is talking about the ventilator work, and the two are different, and it may be why there are some issues that people have identified. So if you put patient on ASV, there's a minimum respiratory rate that's set. Of course, the minimum tidal volume is based on dead space. The high respiratory rate is based on auto PEEP, preventing auto PEEP, and then the high tidal volume or high peak pressure is set by you as the clinician. So there's definitely automation here, and my observation has always been the use of expiratory time constant is the real knowledge within ASV to be able to choose which patients have obstructive lung disease, slow exhalation, so they get maybe a little higher tidal volume and a shorter inspiratory time. And the patients with restrictive disease, ARDS, get a smaller tidal volume and perhaps a longer inspiratory time, or even IE ratio of 1:1. But for every patient, based on their weight, there's a minute ventilation that can be achieved. That's this black line. And that can be solved by any number of respiratory rate and tidal volume combinations. Of course, in reality, it's not. It's really just solved within that little spot here in the middle. This is where we're really talking about. What happens up here is kind of irrelevant. It completes the graph. Sometimes it looks like it gives it more complexity than it deserves. I like this paper by Jean-Michel Arnaud. It's getting to be a little bit old now, but they look at patients who are put on adaptive support ventilation in his ICU in France. And these graphs are very clever. So the dark triangles are acute lung injury or ARDS. The darker but not so light, not as dark as ARDS, is normal patients. So patients with normal lungs on the ventilator for another reason, post-op, something like that. And then COPD. And as well as showing you what the tidal volume was and predicted body weight, the upward slope of the triangle is the inspiratory time, and the downward is the expiratory time. So you're kind of getting an idea of IE ratio here. So for ARDS, the IE ratio is about 1:2. For COPD, the IE ratio is about 1:3 or so. So again, these characteristics show you that the system is able to distinguish between who has obstructive disease and who has restrictive disease and choose the tidal volume appropriately. Now, we haven't talked about exactly how ASV works, but you're basically either, when you read the manual, it'll say it's like SIMV plus pressure support. Hope maybe I'll not talk so long and we'll have some questions, but my experience with ASV, and actually we have some Hamilton ventilators, we have lots of ventilators in my hospital and we rarely use ASV. But my experience is that when you're on ASV, you're either getting all mandatory breaths because you're not breathing, or you're getting all pressure supports because you are breathing. I've never really seen it work like old-fashioned SIMV. And what that shows here is when you move over here to all these active patients that are breathing spontaneously, now the ventilator can no longer control the IE ratio. It's based on pressure support, and the tidal volumes kind of come together a little bit. One criticism of this work or of the technique is here these COPD patients are getting 9 milliliters per kilogram of predicted body weight. And these are medians, so there are patients getting much larger tidal volumes as well. And that has to be an area of concern. But again, you can take care of that by setting the Pmax. IntelliVent is one step beyond ASV, which is at the top here, where they use either the arginate alveoli or the arginate ARMA PEEP FiO2 table. And this is from a paper in anesthesiology, again, from about 10 years ago. So I think this is a smart idea because we kind of had a similar idea that we had done an initial trial with in an IRB at the university. And we said, well, let's use the ARDSNet PEEP FiO2 trial from ARMA to go up. So the FiO2 tends to go up fast. And let's reduce the PEEP and FiO2 using arginate alveoli, which reduces it a little slower. And that's the same thing that Hamilton's done. So you end up with these stair-step increases. But as you look at it on the ventilator, it looks like a much smoother trial. So this just give you an idea how this works. And so what's the data show? So from this paper, this is a typical way of looking at whether or not closed loop works. Here are patients in a normal or abnormal zone of ventilation. So the purples are the end tidal CO2s greater than 55. The yellows are respiratory rate greater than 35 breaths per minute. Respiratory rate less than 12. Tidal volume greater than 12 is in white. See this one patient had big tidal volumes for a while. And then some patients, these are all on pressure support with low tidal volumes. Same patients across the bottom on IntelliVent. And you really only have this one patient who has big tidal volumes and a slow respiratory rate. But for the most part, again, without even knowing what you're looking at, you can say, well, if the more bars and the taller bars are bad, then IntelliVent must be better. Now, having said that, this is another paper by Jean-Michel that looks at IntelliVent versus ASV. And I really only show it to you to demonstrate that with ASV, there were still continued issues of patients getting large tidal volumes. It's only like 5 or 6%, but 5 or 6% is getting 10 to 12 mLs per kilo. And IntelliVent seems to improve that. And again, I'm not trying to be too critical, but most of these studies are physiologic variables. Something is improved. It's lower. It's more normal. It's less abnormal. And I always remind everybody, if you remember the original arginate ARMA trial, which was the 6 versus 12 mLs per kilo, on the first 3 days, the patients who got the 12 mLs per kilo had a better PaO2, a better compliance, and you might have judged they were doing better because of the ventilator, but they died 20% more often. I'm not suggesting that with ASV. I'm just saying don't be seduced by a physiologic difference. And from that same paper, kind of looking at a crossover between when the patient's on ASV, which again, the clinician is setting the PEEP and the FiO2 on ASV, so no surprise, there's very few changes. But during IntelliVent, you have a change in the FiO2 and the PEEP to meet a set SpO2. And so we kind of see all the things I've been talking about. Patients hyperoxic on an FiO2 of 60% and a PEEP of about 8 centimeters or 9 centimeters of water. And you switch to IntelliVent and you have a more variability in the SpO2. When you see the end tidal CO2 starts to rise and the minute ventilation comes down. Again, just comparisons of how these things work. Now, get past IntelliVent. So there are lots of studies that have been done, again, looking at these physiologic variables. And this is another one from a couple of the groups, a number of the authors are employees of Hamilton. But you're looking at the variable, what the lung condition is, and what's the optimal and non-optimal range. And I'll just show you real quick that they're looking at the percentage of time spent in non-optimal and optimal ranges. And clearly within this group, you have people in optimal ranges far more often with Intellivent with respect to tidal volume and the Pmax than you do with other ventilators, and SpO2 as well, by preventing hyperoxia. But what I really want to show you about that data is this, and that's that comparing these two techniques, it's not a huge number of patients. Length of invasive ventilation was no different. Length of ICU stay, no different. Length of hospital stay, no different. Mortality in the ICU, no different. You have a small signal here with mortality, but without a good explanation. It's kind of become the, as editor of the journal, people are always sending me analysis of their data where they say, oh, we did this and then we did that, and it wasn't statistically significant, but there was a trend towards significance. And you don't get to do that. You select this, what's statistically significant and what's not. And when it's not, it's not. You don't get to hedge your bet and say, well, there was a trend. What you found was that there was no difference. One of the other things that gets talked about a lot with closed loop ventilation is, oh, the caregivers don't have to mess with the ventilator as much. They don't have to make as many ventilator changes. And this is another paper by Arnau that was published in the Italian Anesthesiology Journal. And they're looking at number of ventilator changes with Intellivent versus the number of manual adjustments. And you can see huge differences. And I have to admit, one of the first times I had this discussion was with a reviewer at FDA when I said, the therapist doesn't have to adjust the oxygen level or the FiO2. The machine does it automatically, and it helps save oxygen. And the reviewer said, well, who's that good for? I said, well, it's good for logistics. You don't need as much oxygen. It's good for the therapist. He goes, yeah, but we judge things that are what's good for the patient. Where's the advantage for the patient in this? And has been some concern that any closed loop technique might result in lack of vigilance by the caregivers. Go, you know what? I wouldn't have to worry about it anymore. I don't need to go check on that patient. So most closed loop systems now are putting in alarms to let you know, hey, the FiO2 is increased by 20% in the last 10 minutes. And I haven't allowed the patient to become hypoxemic, but you better come in and figure out why this oxygen requirement is increased. And a couple of groups have started to look at oxygen requirement as a marker of severity of illness. Francois Lelouch and Erwin Laher with their NEWS score, with their closed loop oxygen system for nasal cannula. A colleague of mine at UTMB creating what we call the SOS system that alerts you for increased oxygen requirements in non-ventilated patients. So that's kind of interesting. But again, just sometimes what looks like an advantage may not be an advantage. And now I think the most recent thing, and this is published very recently in Critical Care Explorations, is a very small pilot study by Schultz looking at power during adaptive support or Intellivent and ASV compared to traditional pressure control ventilation. And we've all gotten a lesson from Marini and Gattinoni and others over the last year about power, which basically includes the driving pressure and the respiratory rate. And he demonstrates that there are some times when maybe the use of power or the power delivered by the ventilator is reduced when you use ASV, which I think we would agree might be a positive. So let's move away from adaptive support ventilation then, which again, I think the first time I ever put on a patient on ASV was back in the late 80s or mid 90s. So it's been around for a long time. Again, it's interesting to me, we have Hamiltons and nobody uses ASV. I've been other places where they use it on every patient who comes into the ICU. So I think it's like a lot of mechanical ventilation. It's what you're comfortable with and what you're used to. And there isn't a clear signal of improvement. So AVM1 and AVM2, at least AVM1 uses the Otis equation as well, but AVM2 targets the optimum frequency as well. So again, reduces the lowest mechanical power under a given minute volume. So this is just a simple graph showing you the difference between AVM2 and AVM1 related to the respiratory rate as it relates to minute ventilation. And Van der Stay and Rob Chapman have written this paper, another paper that's in, this one's an intensive care medicine experimental from a couple years ago, analyzing adaptive mode ventilation that's using driving pressure, not tidal volume or plateau pressure. And I realize this is a little bit more complicated, but just looking at some of the models that they set up here, and this is all done on a test lung, adult ARDS, adult COPD, looking at the dead space down on the horizontal axis and the tidal volume delivered up here, and you're seeing the differences between adaptive support ventilation and what tidal volume is delivered in black in multi-frequency ventilation, which is a technique that Rob has kind of introduced that, to my knowledge, nobody's put on a commercially available ventilator. And then AVM2 demonstrates that in this model, there's significant reductions in power, which again might have an advantage by preventing ventilator-induced lung injury. This paper in Critical Care by Becker looks at 20 subjects, 10 with ARDS, a very short period of observation, one with AVM2, the second observation period, or AVM1, then AVM2, based on mechanical power. And again, you can see this differences in tidal volume, lower with AVM2, the static compliance, or the plateau pressure, lower, inspiratory pressure, lower, and a significant reduction in mechanical power. So maybe this is the way that we'll go with closed loop ventilation, looking at trying to maximize the reduction in ventilator-induced lung injury. And I have to at least mention closed loop FiO2. Nelson Claret, who's at Miami, has done a lot of work with closed loop control of FiO2 in neonates. And to this day, I am absolutely dumbfounded that it isn't approved by FDA. So this is all Claret's work from the Journal of Pediatrics. So you're looking at the FiO2 during manual control versus during closed loop control, and looking what the mean SpO2 is. And then here we have number of episodes of hyperoxemia, again, lower, number of episodes with hypoxemia, less than 88, about the same. And then number of episodes with even significant hypoxemia, so less than 75%, was less often when you had closed loop control of FiO2. And we go back here again, so the nurses had to adjust, and this is one area where that interaction with the ventilator, the workload for nursing and respiratory therapy in the NICU by adjusting FiO2 to avoid both hyperoxemia and hypoxia is significant. So here you're seeing this manual control of almost 30 adjustments per hour over a 2-hour period, even though the FiO2s are different. And you look at is the FiO2 greater than the baseline level? Is it equal to sorry, keep moving the button here. Or is it less than the baseline level in the percentage of time? With neonatal intensive care unit, we don't have to guess if hyperoxemia is bad. We know it's bad, but we also know that hypoxemia is bad. And closed loop control of FiO2 in that group makes so much sense. And I think, in the spirit of a picture is worth 1,000 words, here's automated control of FiO2 on the left. And you can see the red is the FiO2 going up and down. So when the patients become hypoxic, you can see the FiO2 rapidly increases to 60 or 70%. And then it comes back down as SpO2 normalizes. And then you have routine control. So here, starting at the double bar at the bottom to the right from there, this is manual control by the nursing staff or the respiratory care staff. And you see a lot more incidence of hypoxemia, a lot deeper nadir values for SpO2. And look at all these SpO2s less than 80% that nobody did anything about. So this is an area where, in my initial discussion about where might closed loop have a positive effect, I think this is one. And I know nothing right now about where they're at with their FDA approval, but the failure to have FDA approved closed loop control of FiO2, if anywhere else in the neonatal intensive care unit, to me is a shortcoming at the moment. That's something that we need to see in the marketplace. So this is data from a study that we finished several years ago, all in trauma patients, sponsored by the Department of Defense, with our goal of, again, picking up patients in faraway lands and flying in the back of an aircraft where it's difficult to take care of them for a lot of different reasons. And here's, so this is trauma patients, 4 hours on and 4 hours off. And I'm not a fan of pie charts, but this is a good way to display in controlled mechanical control of FiO2 by the caregivers. You have about 2/3 of the time people are hyperoxic, about 1/3 of the time they're in the normal range, and then there's some hypoxemia. But when you switch to closed loop control, and I always look at this as it's a thermostat for oxygen. You know, if you had to control the temperature in the room, wherever you're at right now, by when you get hot, you get up and flip the switch on to make the air conditioner run. And then when it's been on for a while and you're too cold, you get up and turn it off. You would be doing what is analogous to what we do in the ICU with FiO2. But closed loop FiO2 is just like going to the wall and setting the thermostat. You always want it to be 70 degrees, and it's always 70 degrees. You don't have to worry about it. And I'll just show you again another picture. This is a patient, a trauma patient, and they're on the first 4 hours is closed loop control. You see the SpO2 in red bouncing around, the FiO2 up and down. And then you see here the patient was placed on 100% oxygen because he was suctioned, and then it came back down, and he happened to be switched over to the manual mode. And then it slowly climbed. The therapists were having to increase his FiO2. And then he became more hypoxic in the evening. And this, as you can see, is at 6 o'clock. And I think at 8 o'clock that night, we took him to CT scan. He had a saddle pulmonary embolus. So again, one of the things that closed loop control can do is give you feedback about how the patient's doing without relying on the patient becoming hyperoxic and crashing. And this is another very recent paper published in Critical Care. Look, this is all done. And now I apologize, I don't remember. I think it's either in the UK or the Netherlands, but I could be wrong on that, where they're looking at closed loop control of FiO2 during nursing procedures. So they're showing you the number of patients, the minimal SpO2, the mean SpO2, and the max SpO2. Black is automated control of FiO2. White is conventional control of FiO2. And they demonstrated that, you know, again, no surprise. If you have a machine trying to keep the target, you're much more likely to get the target than if you're relying on a person to do it, who also has 20 other tasks that they have to attend to. But this was an interesting paper. I give them credit. It was a good design. So then let's talk. We talked about, now we're past the ventilation part and we're talking about weaning, and I'm not going to bore you to death with this, but clearly the current standard of care, the guidelines from Critical Care, the American College of Critical Care Medicine, and others. This is based on the work by Wes Ely and his group at Vanderbilt, as well as the guideline that was kind of spearheaded by a physician from the university, from Stanford University. And so you're looking at all the things. And again, I don't want to spend too much time, but awakened breathing coordination, you know, daily spontaneous breathing trials, daily awakening trials, avoiding benzodiazepines, you know, decreasing delirium, monitoring and managing delirium, early mobility, which everybody thinks is getting the patient up and walking, but can be as simple as in the bed exercises or dangling their feet over the side. Early mobility doesn't mean all the ventilated patients have to get up and walk around. And then over here to the right is kind of this is from the ICU delirium website, which is all freely available if you want to go to that website. And they talk about, you know, doing the spontaneous awakening trials, a safety screen. Is it safe? And here are the reasons that make it safe or not. And then you perform that awakening trial, and if it fails, then you start the sedation back. If it passes, then you do the screen for spontaneous breathing trial, and then you perform it, and then you either consider extubating the patient or go back to taking care of them. So this is our standard of care. And you know, the data is pretty compelling that, you know, the ABC approach reduces the time on ventilation and improves outcomes. And you know, this is over the last decade or so, the number that we talk about, the statistic we talk about, the number needed to treat. You need to treat 7 patients using this kind of weaning strategy to save a life. So, you know, protocols make a difference. So, as I said, one of the things protocol automation is good for is protocols. You put the protocol in the intelligence of the machine. So, again, a couple papers about weaning with adaptive support ventilation. It's 97 COPD patients, ASV versus pressure support, and ASV reduced the time to trach collar from 3 days to 1 day, shorter weaning times. But again, always worry, no difference in intensive care unit stay. If you're really shortening the time on the ventilator be ideal. You would expect to see no difference in ICU length of stay. It's kind of like the VAP bundles that reduce the reported incidence of VAP, but don't reduce the number of antibiotics that are delivered. So things to be decided still. Smart Care was initially developed by Dojan and Brochard and was called Neo Ganesh. And I'm sure some of you with our international audience here knows that Ganesh is a Hindu god of wisdom, and I think was chosen because she has 4 hands. But I always tease, Smart Care only changes the pressure support, so it could have been done with the trunk. But anyway, this is kind of just gives you the ideas, and I'm going to show you some pictures about this. Smart Care is an interesting way of taking a bunch of data like you would do, not just the tidal volume, but you're looking at the pressure, you're looking at the tidal volume, you're looking at the respiratory rate, you're looking at end-tidal CO2. There are other variables that go into that. And then you're making a decision. And again, just like I think the brains of ASV was the expiratory time constant maneuver, here it's allowing the patient to make these changes, and it has to be a sustained change before the ventilator does anything. And I think that was a really smart move by the inventors, and why it was successful. So again, just to show you a little bit of behind the curtain, you can go into the settings for Smart Care. You can say, oh, I don't want to wean at night. You can tell it, does the patient have COPD? So you might tolerate a higher CO2. Is the patient head injury or neurologic injury? You might want to lower CO2, or at least avoid a higher CO2. Is it an endotracheal tube, or is it a tracheostomy tube? And again, starts to put the kind of thinking that you and I do at the bedside into the machine. And then they do this, they look at the tidal volume every 10 seconds, and tidal CO2, the breathing rate, and then they make a diagnosis every 2 to 5 minutes and say, is the patient breathing normally? Do they have tachypnea, insufficient ventilation, hypoventilation, central hypoventilation, hyperventilation, unexplained, and tachypnea? So you kind of have, it's not really exactly fuzzy logic, which puts domains in and says, is it normal? Is it, not normal? Is it really not normal? But again, I think clever in the way it was done. And of course, just like the ASV algorithm I showed you before, they're shooting for this spot in the middle here. We want to have normal ventilation. We want to avoid all these other spots within here, tachypnea, hyperventilation, and hypoventilation. And of course, all you can change is the pressure support setting. And the original paper by Francois in the Blue Journal, again, 15 years old now, suggested that the weaning was faster with computer-directed weaning. Now, I've shown this slide a million times. I should probably update it. But even though there were big differences, it was a multi-center trial, and 4 of the sites had protocols, but not every site used the daily spontaneous breathing trial. Nobody looked at the compliance with the protocols in the different places. So what seems to be a fairly large success here might have been the result of what they compared it against. Sorry, I'm looking at my phone to make sure what time it is. Louise Rose published this paper a while ago, looking at 102 patients, Smart Care versus control, and they really found no difference. There was no difference in all the rates of reintubation, but this was a study where you had critical care nurses in 1-to-1 patient care. I don't know that's always possible either. So I have to tell you, between those 2 studies, Francois' study is more of a pragmatic trial. The simple fact of the matter is it might not have been compared to the absolute standard of care, but the absolute standard of care is clearly not practiced everywhere based on the things I showed you from LungSafe. So it's a pragmatic, practical result that I believe probably is true. This is another paper from about 5 years ago from Taniguchi, looking at Smart Care versus respiratory physiotherapist-driven weaning for critically ill adults. And if you look at the reintubation rate, ventilator malfunction, clinical complications in the top table, and mechanical ventilation time and weaning duration in the 2 weaning cases, in this case, there was tended to be an advantage towards the physiotherapist-driven protocol. And as you look through this, the parameters at the start and end, there are some issues here of, very low pressure support levels, PEEP. Interesting that the FiO2 levels are so low, but they were similar, and the patients remained hyperoxic on average, even though they were on 30% oxygen. So this may, again, be the comparator that was looked at. This paper that was published in the Blue Journal looks at automated weaning in the entire study that they evaluated, and found no difference between automated weaning and control. And then they found in the group with sepsis that there was a real advantage of automated weaning, but then they found in the patient with COPD, there was a disadvantage to automated weaning. So like a lot of things, one thing isn't the answer to all problems, and we'll probably have to figure out which patients are most likely to have an advantage on a technique. Again, I think about cardiac surgery, and I was talking with Graham before we got on the program that I can remember as a very young, or as a student, when patients had cardiopulmonary bypass, they'd come to the ICU hypothermic, and we would put them on the ventilator and paralyze them for 3 days so they wouldn't hurt themselves. And now we have patients, get a valve replacement and come to the ICU extubated. But I've always kind of felt like if you went into the cardiac ICU in the morning and just ask everybody who wants to be extubated to raise their hand, everybody who can raise their hand can probably be successfully extubated. That doesn't take a lot of effort. So there is, again, I'm not going to kill you with these slides, and I don't know what the deal is with the slides. If you want to email me, you're welcome to them. There's nothing proprietary here, but here's all the studies kind of listed, all the different trials, what kind of patients they were. Again, a lot of post-operative cardiac surgery patients, what mode was used, the sample size in the different groups, and then the primary outcomes. And as you look at these things in a meta-analysis, and here's ASV versus controlled weaning, and here's smart care versus manual manipulation, there seems to be a signal to the left suggesting that closed loop control might actually give you some modicum of advantage for getting patients off the ventilator quickly. Now, one of the issues that I did mention was about synchrony, and synchrony is a real problem. I think when we do get a patient who's synchronous, it's often more by luck than by plan. But how synchrony improves isn't really addressed yet by many closed loop systems. The AVM system, within the AVM system, there are a couple of issues that look at rise time and how rise time can be adapted to change both the IE ratio and the tidal volume. And the Bella Vista and AVM uses a system called AutoSync. And I'll show you better graphs here, but this is something that's a good reminder, which is why I'm showing it to you, that we think of, well, I'm going to increase the rise time during pressure support, because by increasing the rise time, I'm going to meet the patient's demand, which is true. But as you increase the rise time, you also shorten the inspiratory time and reduce the tidal volume. So there are consequences to our actions that we don't always think about, and we should be aware of. So I think these are some good examples. So on the top, you see essentially a rise time that's or a inspiratory time during pressure support that's too long, and you see that problem by this rise in pressure at the end as the patient starts to exhale. You see here's the end of neural inspiration and the start of active expiratory activity, which you'd like to avoid. Here's the opposite case where the patient's continuing to breathe, but the inspiratory time is too short, and then you get a double triggering situation down here on the bottom, which you also like to avoid. And ideally, what you'd like to do is turn the two graphs on the left into the graph on the right, where you're able to sync up the airway pressure and the flow with the patient's ventilation. Now, we don't have a diaphragmatic signal, that's just for example. So this is this automated control of asynchrony, looking at the automated adjustment of rise time, as well as the automated adjustment of the termination criteria, which I think is really important. It's a really good idea. Yamada and Du presented some data about this 15 years ago when Dr. Du was at Newport. And I think that going forward, this is going to become more and more important, and maybe not even within AVM, just in standard pressure support as well, where closed loop control could really make some differences in asynchrony, because again, the machine can respond on every single breath. I can only go in there, or you can only go in there and make some manipulations, and then we leave. And then what other stimuli come on, we can't appreciate or do anything for. So I'll give you one last graph of that, looking at again the impact of auto rise and auto sync, of how you can set the expiratory trigger sensitivity or the flow termination criteria. At 80%, you have a very short eye time, 50% it's longer, 25% it's longer, and you'd like to maximize these things together, and the rise time would prevent overshoot, but also avoid the patient from doing too much work of breathing. I think there's work that needs to be done there. Okay, and again, I can't, after this last 18 months, I can't talk about anything without talking about COVID-19. Overwhelming number of subjects, limited clinical expertise, both in the US, both respiratory therapists and critical care physicians. When I spoke to people in New York where respiratory therapists went out in the evening with the care of 30 or 40 ventilator patients, you know, in a 12-hour shift, how often can you see each patient? Too many patients, too few ventilators, too few experienced caregivers is a perfect example of a crisis situation that could be fixed by closed loop control. And this very recent placement by Journal of Intensive Care, which is really a stretch, but you know, again, they're talking about anesthesia ventilators as well as the ventilators they used, but they based on their data on the airway pressures and the ventilation of these patients, that about 80% of the time they would have more stable end tidal CO2 using closed loop ventilation. So I think that's good, and I've been arguing that for a long time. And this is a paper we published in Respiratory Care 10 years ago now from China. Again, the standard of care at night was there was only one respiratory therapist caring for a huge number of patients. I want to say it was like 50 or 60. So ASV was a positive answer in that case. So I think that's really important. When you don't have enough resources, closed loop ventilation really becomes an advantage. I always wonder, you know, again, I think about the places you know of that have experts in mechanical ventilation galore. I don't know how interested they are in closed loop ventilation. Now there are factors, you know, or concerns, human factors. Is it usable? How do I know how things are going? How do I monitor it? How do I assess it? There's some concerns about over reliance and complacency. The staff just saying, "Hey, the ventilator's got it. I don't have to worry about it." We clearly want to avoid that. I hear respiratory therapists say, "Well, what am I going to do if the ventilator is doing all this?" Well, you're actually going to do more, because now nobody's going to know what the settings are until you come in and look at the ventilator, and doubtful anybody can explain it other than you. So it's actually a positive thing for ICU people, therapists, physiotherapists, nurses, and physicians. The evaluations that have been done need to, you know, I know it's going to be difficult. I doubt that we're going to find a better outcome, except for in certain scenarios. It's one of those things. If the machine does what the protocol does and you compare it to the protocol, it's going to be really hard to find a signal there. How do you train the staff? How do you simulate it? Again, within all these things, and I know I'm going a little bit long, so I'll move forward from here. And then there are other things. You know, sometimes I turn the PEEP up to match the auto PEEP, not to do anything to compliance or to do anything to oxygenation. Sometimes I turn the PEEP down because the patient's hemodynamics are so bad, nothing to do with oxygenation or driving pressure. Sometimes the high FiO2 is important, CO poisoning. Again, I should be careful here though. Reverse triggering is really interesting, but short of paralyzing patients, there doesn't seem to be anything we can do about it, at least not yet. And again, getting the patient off the ventilator sometimes has other decisions involved. You have a trauma patient who needs to go back to the OR every day and have their abdomen, you know, re-explored and packed, doesn't need to come off the ventilator every day and then get re-intubated and go back on. So there are, you know, always there's a reason, and that's what we're there for. And I'll end with this. This is a diagram that Eddie Fan did that looks at the increasing intervention of your intensity of your intervention going up, and the horizontal axis is your PF ratio. So down on the bottom left is mild ARDS, yellow is moderate, and red is severe. If you're in blue, there's evidence that it's a benefit. If it's in red, there's evidence that there's no benefit. And if it's in orange, it means we need more work on it. So again, I'm not going to explain all this, but clearly low tidal volume ventilation, higher PEEP is better for more severe ARDS. HFOV has kind of been disproven. Non-invasive ventilation is not very good for hypoxemic respiratory failure. Prone positioning, we don't use enough of and is very successful. Inhaled nitric oxide improves gas exchange outcomes. And I put my automation box over here because I'm not sure where I can jam it in over here yet, but I hope someday we'll have those answers. So I'm going to quit there. 5 minutes to go. I see there's one question, Graham, that says automatic adjustments of settings depends on the proper acquisition of signals, which could be corrupted, and they are used to drive the decisions by a mathematical model, which could represent or not the patient actual condition. So the response could not always be best. Can a regular respiratory therapist monitor the behavior of the algorithm that they don't understand, but they have to trust? Yeah, I mean, that's one of the issues. You have to feel comfortable. I'm going to have to tell you, ASV has been around for 25 years and is the same basis for AVM in terms of maintaining tidal volume and providing respiratory rate and minute ventilation that's safe. I think that question's been answered. The questions that haven't been answered are, does it matter? Do we have better outcomes? Do patients come off the ventilator faster? Do they get better faster? Do we avoid ventilator-induced lung injury? But, and I understand what you're saying, and I think about this all the time when I'm, again, I hate to keep bringing up Rob Chapper. And Rob wants to explain to everybody how a ventilator works based on how an electrical circuit works. And since half people don't know how an electrical circuit works, that's not really very helpful. And when PAV came out, everybody wanted to explain how PAV is like cruise control. Well, nobody, half the people, 3/4 of the people don't know how cruise control works, but still drive to work every day. You don't have to know how your internal combustion engine works to get in the car and successfully operate it. And I think that can be true of ventilators. Ideally, you'd have the maximum amount of knowledge. And that's the issue. And somebody's asking, we can't really say this is better than something else. With the evidence right now, we can't say that it's better. We can say that it's as good in terms of maintaining physiologic variables. I agree. I'm sorry, Graham, you want to jump in?
No, that was superb. Actually, you even did better than what I thought you were going to do, which is amazing. I mean, I actually believe, you can actually use it for a lot of patients. It's possible to use it for a lot. It's not for all patients. Surgical patients, you've mentioned well. I mean, the studies from Charles Gamasol in Hong Kong, ASV studies, some of the from Jean-Michel Arnel have worked well. I believe, compare in certain patients, it's probably better than an open loop mode where we've got no clue if the tidal volume that we set is correct, or the I time is correct, or the rate is correct, because we don't measure lung mechanics. How many people come along and you say, look, the compliance is 50, what do I do? And they look, well, I'm not sure 50 is a good number or a bad number, but at least with this, it's safer than, the AVM or ASV is safer than what we normally do. And I mean, I gave an example of David Linton from Israel. He's a big fan of automation. He told me recently he's got over 200 Bella Vistas on COVID patients through many hospitals. And he said, Graham, I've seen no pneumothoraces. I can ventilate them pretty well because we don't have the manpower to manage these patients. So I think there's a place for it. And like you said, Rich, we should look at it a lot more and maybe more targeted trials. For example, the AVM2 needs with mechanical power. That is something that we should look at a lot more to figure out, is that the right direction?
I agree. I go places and visit, and everybody in the ICU goes on APRV. And I go places and everybody in the ICU goes on pressure control, assist control. I go places and every patient goes on IMV. And you know what? The outcomes in all those places is about the same. So it comes down to if you're comfortable with what you're using, you'll probably be successful. But again, I look at automation is protocols taken away from the clinician and put into the machine. And if you would say to yourself, 75% of my patients with ARDS are pretty, standard right down the middle. They're going to be on the ventilator for 5 to 7 days. They're probably not going to need more than 12 a PEEP. They're not going to need recruitment. They're not going to need prone. They're just sick and they're going to get better. And that's where automation, perfect. Again, the guy with an open abdomen and still has intra-abdominal hypertension and, has cardiac disease, that's a guy I don't put on automation. And I let the experts at the bedside make these decisions based on all the information that comes in. But it's clear, like I said, my example has always been in the United States, there are about 1,000 critical access hospitals, which are places that are usually less than 25 beds, often don't have a respiratory therapy department, or maybe they have somebody who's on day shift. And they're not subject to DRG rules and things like that because of their small size and they're providing an essential service. And if those places all have telemedicine. If they had a ventilator that had automated control, the one time they have to use it every 3 months, the patient would be a lot safer than the night shift when the only person there is the ER physician who's a gastrointestinal fellow at the local university trying to manage the ventilator. So that there are clearly places that can work. And Jean-Michel Arnal, I know he's a Hamilton employee and he runs the ICU at his hospital, and he uses it on virtually everybody and does really well. So again, it can be done. The question is there an advantage to it? And as a caregiver, is that what you want to do?
Yeah, I mean, that's right. There's if you like you said, if you believe in it, then you're going to get a better result than.
Sure, of course you are. Champions make everything better. And APRV, there are some places that would never put a patient on APRV. There are other places that's all they ever do. But and of course, then you get the problem that always plagues ICU care, and that's that. Well, I can't do a randomized controlled trial because I know my patients do better on APRV, or I know my patients do better on whatever. But that's a cop out for not wanting to learn beyond what you're comfortable with.
So just looking at, there's actually one more question, basically saying that we really can't say that this type of automation is better than something else. Well, I'll let you answer that.
Well, yeah, it depends on what something else is. I mean,
Exactly.
there are lots of data that I just showed you that if you want your patient to be in a safe tidal volume zone, a safe driving pressure zone, a safe FiO2, automation is clearly better. Whether or not that means they'll get better faster or won't die as often, that's the answer we don't have.
Yep. Okay. Hey, look, Rich, thanks so much. It was a great talk. I think, I've heard these talks a lot, as you know, from you and other people. And that was one of the more stimulating ones that you did a good job, and I really appreciate it.
Okay, no problem. Thank you.
Thank you.